Hello, welcome to another lecture from Jekyll's Epidemiology, Biostatistics, Preventive Medicine, and Public Health textbook. This is chapter 16, titled Principles and Practice of Secondary Prevention. What is secondary prevention? If you remember from chapter 14, when we talked about the natural history of a disease, or the phases and stages of disease, secondary prevention is at the level of the latent phase. It is also, secondary prevention is also the early detection of a disease followed by treatment. So for example, it's early detection because we're trying to manage an asymptomatic illness. So that's the key word here, is that it is asymptomatic. The patient has yet to be symptomatic of the illness. So that's key in terms of secondary prevention. And obviously the ultimate goal is to prevent it from becoming symptomatic. So that's the importance here of secondary prevention. And we'll talk a lot about screening because that is the major secondary prevention activity is in screening. Here are some examples of secondary prevention. So if we're trying to detect and treat hypertension, if we are screening mammography for breast cancer, if we're going to utilize pap smear to detect cervical cancer, if we're going to utilize lipid testing, cholesterol testing for the detection of and treatment of hyperlipidemia. To orient you on other examples in this other stages of prevention, so we have, again, in the last chapter we talked about primary. This chapter is about secondary prevention, and then the last and final chapter we'll talk about tertiary prevention. So an example of tertiary prevention, and it's kind of, the word prevention in tertiary prevention sometimes doesn't make sense here and can be confusing, because at this point the patient does have a disease like diabetic nephropathy. And so in the best case scenario, when they already have the disease, we can still do some early treatment. And that's why the prevention part of tertiary prevention still holds true in this case. And we'll talk more about tertiary prevention in the next chapter. An example of primary prevention would be when folic acid is given as a supplement to, especially in mothers who are expecting, who are pregnant. The folic acid supplementation is obviously beneficial to the potential newborn's livelihood. Another example of primary is the vaccination against hepatitis. And then lastly, another example of a tertiary prevention is precutaneous transluminal coronary angioplasty. I know that's a mouthful, but this is when the use of stents, so this is a medical device that helps to provide a normal blood flow. A stent is usually placed and surgically embedded by a surgeon. And in pharmacy, the stents have relevance in pharmacy because there are stents that are developed, that have been developed and are being developed, that has some pharmaceuticals in it, so that for example, would aid in some kind of disease process where a stent could be utilized as a vehicle for a particular drug. Whenever we talk about screening and its impact, we have to talk about the disease itself. we have to talk about, if you're going to screen a disease, how should the disease look like? What are the characteristics of the disease so that a screening is going to be effective, for example? So we'll talk about disease requirements. Also, if you're going to conduct screening, if you're going to do community screening, your overall healthcare system must have the infrastructure and the mechanism to provide these screenings. So this is healthcare system requirements, and there are several of these as well. And then lastly, as you've learned some epidemiology already, and you've learned a bit about sensitivity, specificity, positive predictive value and negative predictive value. All these are characteristics of determining whether a screening procedure, a screening test is viable, is a good one, is an effective one. So this falls under screening test. So we're going to talk about these three areas next. When you talk about what should the disease have so that community screenings should be implemented, well, you kind of want to make sure that the disease is serious enough that it might cause some or quite a bit of morbidity and mortality. It's going to cause both a decrease in the quality of life and then obviously it could be deadly. There must be an effective therapy for the disease if it is detected. So this makes sense. You don't want to do screening for a disease and not have a cure for it, or not have some kind of prophylaxis for the disease. You should have some kind of treatment for it. That only makes sense. Another criteria is kind of understanding the pathophysiology of the disease, or the natural history of the disease should be understood. By knowing the pathophysiology of the disease and the etiology of the disease, this will allow time for treatment or cure if it is detected. So if we know that the disease process is going to be a very short acting one, for example, in Ebola, we know that once you're infected by the virus and once you start to exhibit symptoms, it literally is a matter of days before you die. So taking into consideration that short time period of the natural history of the disease, and for example, comparing it to maybe hypertension, where you could be hypertensive and live for a very long time, kind of balancing and understanding the time of which a disease can impact mortality it is going to be something that you'll want to balance out when trying to determine whether to implement a screening program or not. And then lastly, considering whether a disease is too rare or too common. So from a epidemiological standpoint, from a diagnostic standpoint to be more specific, we know that if a disease is too rare, there's going to be a high number of false positives. Conversely, when it's too common, then you might have some high false negatives reading. So the data, diagnostic data, the epidemiological data here should also be weighed and balanced with respect to for example, the overall effectiveness of the screening as well as the cost. So what are the requirements for screening? Well, it would be very nice because if you're doing this from locally to a more wider range of population, for example, a state or region, even an entire country in terms of epidemics. It is nice to know that a screening can be quick, easy, and inexpensive. The tests should be relatively be safe and reasonable for patients. Uh, Meaning sometimes it's good that a test is not invasive and that it's not causing discomfort to patients. And because if that's the case, you probably have a lot of people who don't want to participate in a screening. We talked a little bit about kind of some of the test efficacy should be known. We talked about the sensitivity, specificity, positive and negative predictive values. So the test must have these values so that not only clinicians but the entire healthcare system, from the payer, the insurance company, to obviously regulatory agencies like the FDA, they're going to be approving some of these diagnostics. They're going to want to have these data as well. And then related to that is considering the rates of false positives and false negatives for a test. Well, what if we also want to understand more broadly the requirements at the healthcare system level? We want to make sure that the screening is defined for a particular demographic population. Is there a certain age? Is there a certain gender for the screening test? And we want to make sure if the test is positive, what are the available treatments? What is the available follow-up care? So this is kind of all about having a positive screening test result. So what's next? What's the follow-up? Or is there also the follow-up? And then lastly, I mean, this is kind of common sense, but the treatment should be acceptable to the population being screened. All right, so let's just get into a little more detail and specifics regarding the benefits as well as harms of screening programs and certain diagnostic tests. So the benefits when working appropriately, screening and diagnostic tests can help reduce morbidity and mortality because they're detecting a disease, and so you and the healthcare system can follow through, and get the appropriate care. And along those lines, both the patient and the public they become reassured that a particular disease, one that causes both morbidity and mortality, that it can be detected by the screening program or the diagnostic. The harms we've also mentioned in the previous slides include false positives and false negatives. So with false positive, the test shows that you do have the disease, says that you do have the disease, but in fact you don't. Whereas the false negative shows you don't have the disease, but in fact you do. So with both of these cases, they're both disadvantages, and they're both negatives with respect to screening programs and the harms that it causes, because false positives cause human resources to be taken up, like time, cost. How about the mental anguish and the emotional problems that, like anxiety, that can be caused by false positives. And then with false negatives, you think you don't have the disease, and so this obviously causes a very serious misdiagnosis. And the below, the colon cancer screening as well as the breast cancer screening demonstrate some some of the positive outcomes of screening. So in colon cancer and in other cancers for that matter, positive screening can lead to a limited and curative surgical resectioning. Yet you're detecting the disease early versus having it go on further where major surgery might be needed and other very costly treatments and more dangerous treatments might be utilized. So in this case, having the screen become negative can be reassuring. Or on the flip side, if there is a positive screening but you've caught it early enough, then obviously that's a benefit to the patient. And there are some controversial screening programs and diagnostic, like mammography. As you have read in the chapter, in the past, there's been kind of a policy to conduct mammography as early as 40 years old. In the past, it was strongly recommended that those who are 40 to 49 years old get regular mammography screening. But over time, studies have shown that this might not be such a great idea, as it can lead to a high number of false positives. And so mammography can detect benign lesions and artifacts that can also lead to unnecessary biopsies. So this is kind of a key word here, where you might have, again, some false positives, and if it's a false positive, it can lead to these unnecessary biopsies and surgeries, and the financial, psychological implications along with cost can be very unnecessary. And the last bullet here, and on the flip side, mammography can sometimes miss cancer. So this is a case of a false negative. This is a case of a false negative. So unfortunately, the sensitivity and the specificity of mammographies over time probably have not been as good as other tests. So you have the epidemiological data to determine whether a screening program or a diagnostic is a good one by, for example, using sensitivity, specificity, the positive and negative predictive values. Another set of factors that should be taken into consideration are these three biases: selection bias, lead time bias, and length time bias. And a selection bias, so sometimes those who are more at risk get the help. So a selection bias sometimes occurs when we know that a group, a sample of the population knows that they're more at risk, and so they get more help. So, which you would think that's a good thing, but there's the flip side of a selection bias as well, where uh, the people who might need it most is not actually getting the the help with respect to getting screened for a particular problem. So making sure that selection bias is removed as much as possible, and sometimes screening programs must be very deliberate in terms of who is going to qualify for these screening programs. The community, the institution, the healthcare system must be very good at communicating uh, the the activities of the screening program, and probably most importantly, policies with respect to uh, the demographics of who's eligible for screenings definitely have to be in place and implemented at all levels of the healthcare system. Now, lead time bias and length time bias, these two have to are impacted by kind of the natural history of the disease, as well as when you're actually trying to detect a disease. So let me go on to the next slide. The next slide actually shows the good visualization of lead time as well as length time bias. So with lead time bias, although we've diagnosed the problem, you'll die anyways. What's happened here is that we're actually just detecting the disease earlier, and it's not necessarily changing when when your time is going to come, when you're going to die, unfortunately. And then with length time bias, if you live longer, it's because screening has worked. So sometimes the longer the disease impacts you, then screening is going to work. So let me go on to the next slide to show you what that looks like. So here's lead time bias. So there's going to be a bias in the screening when there's the disease onset, so the disease starts, and then the disease continues in this occult stage where perhaps this is a pre-symptomatic stage, and then it continues to this overt stage where it becomes symptomatic, and that's why we can clinically detect it at this stage. So with screening, when you screen this particular patient, they are screened and we detect the disease at age 45. Okay. Now, remember, this is the occult stage and is pre-symptomatic, so they're not having any symptoms, but perhaps we have a biological factor that we can screen for and detect that leads us to the particular disease. So the difference between when the screening detection versus the clinical detection is 5 years, but the death is always going to occur at age 60. So what screening has done is that it's just given us the knowledge that you're going to live a total of 15 years versus 10 years when it's clinically detected at age 50, but you still die at age 60. So what policymakers sometimes say who are against screening is that, well, your disease, regardless of whether it's detected during screening time or when it's detected at during a health screening, for example, and to the time of death, the time of death is going to be the same regardless of the screening or not. So this lead time bias is kind of fuel for those who might have issues and want policies that are kind of anti-screening, if you will. With length time bias influences the number of people detected. And depending on the disease, if a disease is slowly progressing versus a rapidly progressing disease, we can see that in very rapidly progressing disease, during the time of the test, we're basically detecting only 2 cases versus a disease that shows a slowly progressing disease where in the 6 cases, we're detecting at least twice as many people who are going to be detected for a particular disease or screened for a disease. So length time bias, you just have to be, this is a criteria where you want to be cognizant about the natural history of the disease again, where if you know that you're going to have slowly progressing disease, that you might detect the prevalence of disease might be greater with a slowly progressing disease, whereas a rapidly progressing disease, I should say the incidence, right? The incidence is probably a better term to use here. The incidence here would be quite lower uh, in the rapid progressing disease versus slowly progressing disease. So just a couple of biases that clinicians and scientists, policymakers want to know so that you can prepare for your screening. So traditionally and historically, the periodic health exam was the most common method of prevention. It was a way for adults to get annual physical examination or the checkup. And not only this involved medical history, the physical examination, complete blood count, urinalysis, chest x-ray film, and even electrocardiogram to detect the heart rhythm and heart arrhythmias that might cause morbidity and mortality for an adult. And this was the standard of care prior to the 1970s. And it was also very limited because many insurance companies wouldn't cover uh, the physical examination. However, once, remember in the 70s when HMOs, health maintenance organizations, when they started to grow, they in turn knew what was a good diagnostic tool, was a good tool for prevention, was to do periodic examination. So with HMOs at least, having a yearly physical be covered as part of a health insurance plan, that was common for HMO insurance as they grew. Uh, but however, even then, physical examinations, when they weren't covered, They weren't cost effective, and sometimes they weren't testing the right, they weren't testing for the right disease or a disorder for a particular group. So that's where we kind of move into lifetime health monitoring. And so over time, the the physical examination has become more specific with respect to age groups. So it's targeting a particular gender and age will have a different screening and counseling criteria, for example. And this became first recommended in Canada in 1979 and then advocated by US and the Canadian preventive health experts. And as we know, Canada is kind of a leader in putting a lot of efforts in their primary care and therefore prevention. So in many ways, the Canadian system has a lot of has had a lot of innovative activities with respect to secondary prevention, and in this case, utilizing physical examinations and now termed lifetime health monitoring to screen for particular individuals and in particular diseases. From a regulatory standpoint and from a national policy standpoint, the United States Preventive Service Task Force, who are experts in providing recommendations in prevention, they kind of set forth guidelines in not only screening, but counseling, and even specific immunizations and chemoprophylaxis to prevent specific diseases. So you can imagine even the current state of our national as well as a global epidemic as it relates to the Ebola outbreak, particularly in Africa, that this agency, this task force, as well as other agencies like the FDA and the CDC, who are trying to detect as well as find a cure for Ebola, that this task force is highly involved in informing the public, in creating an action plan, in promoting the vaccine for Ebola, and then of course, properly screening individuals, counseling, and educating people who are, for example, traveling to Africa, especially areas where they might have high incidence and prevalence of a particular infectious disease. And then again, specific immunizations and vaccinations that obviously would prevent some of these very highly infectious diseases. Another government, the actual agency that this task force falls under is ARC, and you can see here the website that you can go to get more information with respect to screening and secondary prevention at the national level. So to conclude, secondary prevention involves the early detection of asymptomatic disease. So that's the key word here, is that they don't have the symptoms yet. Appropriate secondary prevention screening must meet certain criteria of the disease, of the test, of the healthcare system. And then finally, we do have a national task force that recommends and guides secondary prevention activities in clinical practice.